Now, I don't know whether any of you have seen a visual evoked response. Basically, you put a patient in front of a screen, and then you measure the time it takes for the image to get to the occipital cortex. You can actually look at the function of the optic nerve, optic tract, all the way back to the occipital cortex, where it is stored. Now, what you'll get a nice response. Now, if the response is large and delayed, that usually tells you it's a demyelinating. If you get it very small and delayed, that's axonal. And if it is really axonal, then the prognosis is bad, because that means there is damage to the axons. So that might help you in differentiating between the two. I mean, if you have a case like this, it would have been quite useful to do a visual evoked response. And if you find that it is really the actual response is quite big, but it will be, as I expect, delayed and not really much affected by as far as how big it is, then that would tell you the prognosis is probably better. Now, if you find somebody who's really lost the signal, or it's really very small, that will tell you it is axonal, and maybe the response will not be as good.
I want to ask Ammar Ubaideen about this. Papilledema and pseudo-papilledema. How can we differentiate, especially for young people?
Simply, both they have normal visual function. And visual field can differentiate, and fluorescein angiography can differentiate. But just one comment regarding the patient. The patient has optic neuropathy in the sense that he has impaired color vision. He was counting finger. So the region is proximal to the lamina crepiosa. That is to say, the posterior part of the optic nerve. As Maurice said, you can do visual evoked potential to just confirm the presence of the optic neuropathy further, but simply you can do a simple clinical bedside test, just doing looking for markers, gun pupil or relative afferent pupillary defect. So I think clinically we can tell easier than before going into visual evoked potential.
And sometimes because of the adhesions of the arachnoid around the optic nerve, sometimes the intracranial pressure is not transmitted to the optic nerve to see it by fundoscopy. Isn't that correct?
Yeah.
دكتورة سنة.
طبعا أشكر عمل الفريق بينكما، طبيب العين الحاذق وجراح الأعصاب الرافع. هذا جيد، ونفتقر كثيرا أحيانا في بعض الأحيان في الأردن لعمل الفريق. تعليقي، رأيت في الورقة ذات الموافقة كلمة فوبيا. كطبيب تعرف أنها فوبيا، ولكن هل المريض يفهم ما معنى الفوبيا؟ لماذا لا تعطى كلمتها الصحيح باللغة العربية؟ إنها رهاب الضوء. عندما تقول رهاب الضوء يفهم المريض عندما نوقع على ذلك ما معنى الفوبيا. شكرا.
دكتور عتامني، راديولوجيست. دكتور
كومنت صغيرة، يعني لما نذكر الانوريزمال بونسيست على طول بيخطر على بالنا الجاينت سيل تيومر. الفرق بين الاثنين تقريبا، يعني مش دائما، انه الانوريزمال بونسيست يحترم البوردرز والجاينت سيل لا يحترم. سؤالين صغار دكتور ابراهيم. اولا التيومر او الانوريزمال بونسيست هل له وول او ما له وول؟ وقديش نسبة الانسيدنس اوف ريكارنس في الانوريزمال بونسيست؟
The last question first. The incidence of recurrence of aneurysmal bone cyst is 20 to 40%. And there is no border that you can see. It is made of many septations, many compartments. So there's no border that you say, I have completely removed it. Especially that it goes to the bone, especially if the bone is discolored.
Thank you very much for a very nice lecture. My question, you said that the MRI findings, especially fluid level, is pathognomonic. but I think it's not pathognomonic because they are different. Lesion can give fluid level as giant cell tumor, chondroblastoma, and osteosarcoma. So I think it's not pathognomonic, but if you find multiple fluid level with sclerotic or hypodense lesion in T1 weighted with multiple septation enhancing and the fibrotic band enhancing, it's in favor of aneurysmal process.
If you see bone level, fluid level in a bony lesion, the first differential diagnosis is aneurysmal.
Yes, one of the differentials. Thank you.
Hence, Dr. Atami, what we discussed is the possibility of this having the giant cell tumor or chondrosarcoma or osteosarcoma. These are actual real parts of the differential. These were actual cases. It's not hypothetical. What else could this have been? And the importance of the surgical approach in all of those cannot be overemphasized. I can't agree with you more.
Dr. Mohammed Al-Asadi, NT.
شكرا. The first slide, you said about the way of management. You said the external approach and then endoscopic approach. Sure. Just to mention that these things, it could be, in each case we have to evaluate, but it could be done endoscopic without any external approach. Most of the maxillofacial, they like external. But most of the ENT, they would prefer endoscopic. Now endoscopic has become a very, very wide approach, and we can reach to the skull. The main things for the patient was the art. And this can be easy when we open the anterior ethmoid, the lamina papalucia will be pushed and then the eye will come. And we have seen, I had many cases, on the spot, on the table, the eye comes back. And with the ophthalmologist with me, once we remove the tension about the lamina, the eye comes proptosis or deviated or double vision or something like that. This is just to mention, and it is up to the surgeon and the approaches. Thank you.
So the message from Dr. Mohammed said that there is an endoscopy approach for this, which I agree to. My question is, can endoscopy remove such a giant tumor? I say no.
My question is about, was there any lacrimal syringing done pre or post-operative?
I can't honestly remember whether this was done or not. Most likely,
symptomatic, no symptoms.
Yeah, no symptoms. Yeah, exactly. But I can't really, with honesty, say yes or no.
Question: if this occurs, you go back and do another surgery?
Yes.
You go do an angiogram, injection?
I would go for surgery. And if there is remnant, I would think of other options. Surgery is the key for this. Dr. Sazif Haddad, interventional radiologist. Any questions? Okay, with this we finish. I thank you all. And we will meet next week at the same time with a very, very interesting case. It is toxoplasmosis in the spinal cord presenting as a spinal tumor in HIV positive patients. So we will raise the question of HIV, etc. So thank you very much.
ابراهيم الدهني زي دم very nice, very special. ده يدرس على الأطفال.
طبعا.
Very interesting.
My diagnosis was giant massive.
لازم نحكي